Pues empezamos con la segunda tanda de presentaciones esta mañana. La primera corre a cargo de Paul Grossfeld sobre terapia génica para la discapacidad intelectual y el autismo en síndrome Jacobsen. El profesor Grossfeld, como todos conocéis, es una autoridad mundial en Jacobsen, es un cardiólogo pediátrico de formación inicial que a través de anomalías congénitas cardíacas se fue introduciendo en esta alteración genética y tiene un grupo de investigación precisamente sobre diferentes alternativas terapéuticas para los problemas relacionados con Jacobsen. O sea que sin más. Paul.
Ok, gracias. Primero voy a hablar un poquito en español, solo por un poquito. Primero yo quiero decir muchas gracias a Jimena y Cosme para preparando esta conferencia. Yo sé que es mucho trabajo, pues gracias. Para yo es un honor y privilegio muy grande para estar aquí. So, otra vez, gracias. Y también de mi familia, gracias. Okay, now I'm going to change to English before I embarrass myself with any more bad Spanish. Pero espero que en la futura yo pueda dar una lectura solo en español. No todavía. All right. So I think we'll have plenty of time at the end for questions. And what I'm going to talk about in this first talk is, as shown here, gene-based therapies for intellectual disability and autism in Jacobsen syndrome. And I'm not going to talk today about anything regarding the heart research that I talked about 2 years ago. However, it's important that the approaches that we've used for the heart gene and the heart story we've used and kind of adapted to study the story about intellectual disability and autism. So it's a very similar approach. Okay, moving on to the next slide. So I think all of you can appreciate that just even in looking at the room last night with your children, there's a lot of variability. And I think that's a very important concept, not just with Jacobsen syndrome, but with most syndromes, that there is a lot of variability both in the intellectual disability and in the behaviors. This describes the approach that we have taken, so not just myself, but many others, including Natasha and Sarah and some others that I'll talk about later on. So first, what we need to do is to determine the exact breakpoints of the deletion. So we use that technique that Dr. Martina described, the array comparative genomic hybridization. And in addition to defining the exact deletion and knowing what the genes are, we have to do a very detailed assessment of the cognition and the behavioral problems. And that's exactly what I've been working on with Natasha and Sarah now. What did you say, since 2010, but even before that in San Diego. From that, we can begin to identify potential genes. For example, if someone has some clinical problem and that gene is always lost in those children with that clinical problem, we begin to identify those as candidate genes that we want to study further. But as you can appreciate, there's only so much we can do with humans, and that's why my lab and others that I work with use animal models to begin to study further those genes, to learn what they do, to hopefully begin to identify potential therapies that we can bring back to help your children. Okay? So Sixto asked me when I started studying Jacobsen syndrome. This is my first patient that I saw in July of 1995, so exactly 20 years ago, in my first month of training for cardiology, and he has heart problems. And I still take care of him now. So he was about 7 years old in that picture. He's almost 30 now. You've seen this kind of picture before. You'll never see it again because this is very old technology. But you can appreciate, and this is actually that boy's Edgard's karyotype, you can appreciate that there's a piece of the chromosome missing. And I got very interested in that because I thought, there must be a gene or genes in there that are responsible for his heart problem. And so I've spent a lot of time trying to figure out what's in that chunk of chromosome that's missing. But that's great to give you just the diagnosis, but it doesn't give us any information about the genes. And so Again, you've already heard the microarray or CGH, and this is an example of what one looks like. And from that information, we can get a readout of exactly what genes are missing and what genes are not missing in your child. And so in terms of behavior, this is just a list of the standardized testing that we do, that Natasha and Sarah have done over the years. I'm not going to go over it because I don't know that much about it. But it's very important to use standardized tests. And I'm quite sure that these tests are done in many languages, correct, Natasha? So it can be adapted to your children. So I want to summarize sort of the overall results, and then I'm going to go into more detail. So not surprisingly, we found that there is a wide range of IQ, from really low normal, maybe about an IQ of 80, to very severely impaired, so low that it's even very hard to measure. And what was nice to see is that there was a very strong correlation, as Natasha also showed you, between the size of the deletion and how severe the intellectual disability is. And that was very, very important because it would then allow us to be able to look in those regions where the genes might be. And I'm going to show you the same slide that Natasha showed you in a few minutes, showing where we think there are at least, and probably more than, 4 different genes up and down that part of chromosome 11 that contribute to these problems. And just to start out, I want to tell you that the region that's furthest up on the chromosome has a gene that we think is absolutely the gene that causes the most severe intellectual disability in those people that have the biggest deletion. So again, this is that same slide. Let's see if my pointer works here. So this is the region that has the gene that is responsible for the most severe intellectual disability when combined with these other regions. So these are the 4 regions. If rarely we have seen a child that has just a small deletion across any one of these separate regions by itself, in general, those children are not very severely affected. It's only when you have more than one of these regions deleted, like let's say 1 and 2, 1, 2, and 3, or 1, 2, and 4, that you get the most severe. Going from the end of the chromosome, if you have, let's say, just 4 deleted, so that's a small deletion, that's mild. 3 and 4 is also mild, maybe a little more severe. 2, 3, and 4, relatively mild, maybe an IQ of 65. Okay? So 2, 3, and 4. But if you have a little bit bigger deletion that goes across this first region, 1, that has this gene called BSX, again, that's what gives you the most severe. And that's basically what all this says down here. Okay? So specifically, if you have a deletion that goes through all 4 of these regions, which is more than 12 megabases, or 12 million DNA base pairs, DNA letters, in every case that we've looked at, that IQ score is less than 50, without exception. And that's a large number now that we've looked at. If your deletion is smaller than that, in most cases your IQ is not as low. It's quite much higher. And that's pretty much what I just said in this slide. Again, all patients with a deletion size greater than 12 megabases are the ones that are most severely affected. This is just another way of showing that those patients with the smallest deletions have the relatively higher IQs, maybe average about 75. If they're a little bit bigger, the IQ is a little lower, but still in the relatively mild impairment range. But then once you get past that 12 megabase, as you can see here, from a medium to a large deletion, there's a pretty significant drop from, again, IQ of maybe in the 60s down to maybe 40 or even less. Does that make sense to everybody? Okay. And at any time, if you want to stop me to ask questions, that's fine. This is just another way of kind of showing in a little more detail what I just described. And down on the bottom here, let's see, where's my pointer? There. So this is a deletion that comes up to but just before that number 1 region, and this patient is only mildly affected, whereas if you go a little bit bigger, past that region 1, every patient with a deletion that goes up to here or bigger is much more severely affected. With that information from that genetic mapping, we can look and see what genes are in this critical region that distinguishes this patient from this patient, and there are only just a few genes in that region. And it's kind of satisfying to see that one of the few genes in that region actually is called brain homeobox protein, which means it actually has the name brain in its, the word brain in its title. So if you're looking for a brain gene, it's nice to see that the name has the word brain in it. All right, so what I want to spend the next couple of minutes talking to you about is the research that's been done on this gene, primarily by a collaborator of mine in Berlin, Dr. Matthias Trier. And I'm just going to summarize for you in this slide many, many years of very important work that Dr. Trier has been doing. What Dr. Trier has shown is that this BSX gene, or protein, acts as a switch that regulates 2 very important aspects of behavior, appetite and sleep. This gene is only expressed in a small number of neurons in the brain, in a part of the brain called the hypothalamus and the cerebral cortex. Basically, what Dr. Trier has shown is that this may act as a switch to allow parts of the brain important for cognition to either be awake or asleep. So when I first contacted Dr. Trier, he had mice that he had created that are missing this one gene. So the first thing he did after I talked to him was to go back and study these mice to see how their intellectual function is when they're missing this gene. Just this one gene, not a deletion like Jacobsen syndrome, just this one gene. And clearly what he found is that these mice, if they're missing actually both copies of the gene, which you can do in the lab, were very, very severely affected. Okay? I'm not going to go into a lot of detail, but he has also worked out through some very, very elegant technology how this gene or how this protein functions to signal the brain. And what he found is that there's a very specific chemical in the brain that this signal or this gene regulates called histamine. You've probably heard about histamine for allergies, but histamine actually also has some very important functioning in the brain for signaling. And it turns out there is a drug that can be used to improve this signaling process in the brain. So that if your child is missing one copy of this one copy of this gene in the brain, meaning that signaling pathway is now decreased, treatment with this drug called modafinil can maybe boost up that signaling to normal levels. So what is modafinil? I'm not an expert on this, but it's, in the United States at least, it's an approved drug that's very safe, that's already been used for treating narcolepsy, for anxiety, and interestingly, even though no one yet has known why, intellectual disability. So, how can we apply this information now? We've characterized the patients, we found a gene, and now we have maybe a way to treat that. So right now as I speak, in San Diego, there's one child who has a very large deletion, who's very severely affected. And there's also another child on the East Coast in Maine who has not a whole long deletion, but an interstitial deletion, who's also pretty severely affected. And her interstitial deletion includes the BSX1 gene. And so we are going to be starting very soon treating both of these children with modafinil to see if maybe they will improve. So that's where we are with that. But I think this could be potentially very, very important and very helpful for those of you whose children have the BSX1 gene deleted. Does that make sense? Questions? Okay. So I'm going to not spend too much time on the autism story because Natasha already told you in great detail about that, but this is the first child that I learned about back in 2004 at the European conference, actually. That's her mom with her, and I was actually very surprised because I had never heard of anybody with Jacobsen syndrome being diagnosed with autism until this child. Natasha already showed you this slide, but this is how we were able to narrow down the region, we think, to find the gene that we think, one gene that is the cause or can be a cause of autism in your children. And if you can see up here, that little region does not include the CURL3 gene. See, I knew that question was coming. But it does include this other gene called RIX. And I think Natasha showed this picture as well. This is that child with that very tiny gene. I'll go a tiny deletion. This is that tiny deletion. This is that deletion blown up. And again, you see here just a few genes, including this gene that's also called RIX, or here ARH-GAP32. And it turns out already, thanks to a group in Tokyo, there was a lot of work done on the function of this gene. Don't worry about the details here, except to say that we already knew, thanks to this group in Tokyo, that this gene seems to have a very important role in brain development and brain function. So what I learned when this story developed a few years ago, the first thing I did was email this group in Tokyo to ask them if they might be interested in collaborating with us to learn more about how this gene may cause some of the problems that your children have. So question number one I asked them is, they already had mice that have this gene deleted or missing. I asked them, could they go back and study their mice to see if they might have autistic features? And that's what they did. The second question I asked is, based on all the very elegant research they did on how this gene or the protein functions, could there be a potential therapy? And I know I talked about some of this before, but I'm going to kind of give you an update on where this story is developing. First, I just want to show you now what they showed me a few years ago. I actually was in Tokyo for a cardiology conference, so that was really nice to get to meet them. And I'm going to show you, hopefully, is this going to work? I might need help in the back of the room. Let's see what happens. Here we go. So on the left is a normal mouse. Here we go. And on the right is a mouse that's missing this gene. And I think when you watch this, you can see the difference in their behaviors. And this kind of repetitive digging that you see on the right is one of the classic behaviors observed in autism. I like movies too, it's kind of fun. And I think you get the idea. The happy mouse on the left, he's looking around at his environment. The mouse on the right is a little more preoccupied with digging and this kind of repetitive, not very thoughtful movement. Okay, I think you get the idea. And in fact, they can quantify that behavior. The blue is the normal mouse. The red is the mouse that's missing one copy, like most of your children, and the green is the mice missing 2 copies of the gene. And even the mice with missing 1 copy of the gene, like your children, clearly demonstrate this repetitive digging behavior. And they went on to do some other testing, a whole kind of battery of tests for autism in mice. One of the other things they looked at is their ability to socialize by using their sense of smell. So this just shows that whether you're normal or missing 1 or 2 copies of the gene, their sense of smell is fine. If you give them a piece of food, they come right to it. So they obviously can smell that. But for other kinds of smells that are more involved with social interaction, what they very clearly showed, sorry, where's my pointer here? It keeps disappearing. There we go. Here's a normal mouse in the blue. The red is missing one copy of the gene, and the green is missing both copies, and you can clearly see that if you're missing one or two copies of the gene, they do not respond to social cues through smell as well. So they're not very friendly, basically. Don't worry about this slide. This is a very busy slide, but the idea, though, is actually a very important one. This blue is actually the RIX protein. And what my colleagues in Tokyo determined was that this protein has a very important function to connect a protein that's very critical for signaling in the brain. And that's what these four things are. Okay? And if you're missing this blue, then that messes up, or that gives you less of this receptor protein, these receptor proteins. What they hypothesized was that if you are missing, or if you have less of that blue, if you have half the number, like half the amount, like your children have, then you're going to have half of the normal amount of this complex, this receptor. And if that's true, is there a way that you could compensate for that by making that lower amount of protein or lower amount of receptor work harder to offset the lower total amount? And they determined that a commonly used drug for anxiety called clonazepam can do just exactly that in these mice. And so what they showed was that treating these mice that I just showed you with clonazepam can actually help with some of these autistic features. Again, by stimulating that receptor that I just showed you to compensate for the lower total amount due to the loss of that gene. Now, since the last conference here, we've had a very exciting development because there was a very good question asked before about that other gene, KIRO3. And until we started really doing these studies, we didn't really know if it could be this gene and or other genes. But because I do pay attention to Facebook once in a while, I actually learned about a very, very interesting family in Texas where their two children were actually diagnosed with Jacobsen syndrome. But actually, they don't have Jacobsen syndrome. What it turns out, both the father, shown here, and all three of their children have is a tiny, tiny deletion in that part of 11q that contains just that RIX gene, the RICS gene, in other words, the autism gene. So we flew this family into San Diego last summer. Natasha and Sarah did some very comprehensive assessments, and they're continuing to get assessments. But what we learned, what we already knew somewhat, but in more detail, is that basically at least two of these children, and maybe all three, and maybe the father, have varying types of behavioral and maybe even cognitive problems. So the youngest son is actually very severely affected. And correct me if I'm wrong, Natasha, but it's very clear he seems to have autism. Correct? The older brother is more mildly affected, but he seems to have some problems as well. The daughter has some behavioral problems. We don't know if that's the same or different. And interestingly, even the father told me that when he was a child, he was teased because he didn't have good language. He had a speech problem. And again, this is just a very close-up, blown-up view showing their deletion, which actually goes from here to here. And that deletion takes out, basically knocks out this autism gene. So this family is actually the perfect family to ask the question directly of whether or not clonazepam might help with the problems. So we are finally, after a lot of effort, working with a developmental pediatrician in Houston. And in the near future, at least one of these children, the one that's most severely affected, is going to be started on low-dose clonazepam to see if there might be some improvement in his behavior and cognitive function. Does that make sense? Any questions about that? Okay. Last time I was here, I showed this slide, I believe. This little girl is, again, from the United States, and she was participating in an interesting study because she had been diagnosed with autism. I did not show you this slide before, and you really don't want to see this now, other than to look at the title. She was participating in a study to determine whether or not a commonly used drug for depression called buspirone might help with some of the features of autism. And what was found is that it didn't really help a lot of the features like the social problems, but it did seem to help with some of the repetitive behaviors that these children with autism have. Don't worry about the rest of the slide, that's all you need to know. It was also interesting that it was very dependent upon the dose, and so when there was a low dose, there was an effect. When there was a higher dose, there did not seem to be an effect. So the dose of the buspirone was very, very important for probably some complex pharmacologic reasons. So Dr. Shugani, who led that study, also told me that there's some evidence suggesting that buspirone and melatonin together may help some of these problems, like the repetitive behavior. But what I didn't tell you, I did tell you this last time, going back to this slide, is that unexpectedly, even though she didn't have really much improvement in her autistic features, she did seem to have, according to the parents, a very dramatic improvement in her cognitive function, in her daily life skills, which I think Natasha described before. So it was almost by accident that this was discovered, but it raises the very interesting question, could buspirone help your children with maybe some of their intellectual disabilities? And again, as I mentioned here, she was treated for 6 months, and she seemed to have a dramatic improvement in her daily living skills. So over that 6-month period of time, her living skill score improved by 2 years, which is pretty dramatic. But that's just one patient. So ideally, if we had a lot of time and a few $1 million probably, realistically, the best way to study this would be what we call a prospective study. And I'm not going to go through all the details here, but this is kind of the plan that we would ideally like to do, is to get a large number of children like yours and others, start them with a low dose, a higher dose, maybe add melatonin, and during the time that they're being treated or given placebo, study their intellectual disability and their behaviors. Okay, that would be the ideal study to do. In the meantime, as you know, we have this conference every 2 years in San Diego, and one of the families that has attended that conference very regularly is from Northern California, and the parents are very savvy, and they went back to their child's psychiatrist and told them about some of our research, suggesting that both buspirone and or clonazepam might help their children. So what I recently learned, I didn't know this until just a few months ago, is that this young lady, Kalia, has actually been treated in the last year or two with both clonazepam and buspirone. Since that time, her parents think that there has been dramatic improvement in her language, in her autistic behaviors, and in her cognitive function. We had actually already done some assessments on her back in 2012 before she started on the medication, and even before that, back in, I think, 2006. So we have several assessments from prior to the time she was started on this medication. And what we're going to do is bring her back now that I just learned about this, and Natasha is going to do a follow-up assessment to see if there may be anything that is consistent with what the parents are saying that suggests that these drugs may be helping her. So this is Kalia on the left. And I wanted to review for you the notes that her psychiatrist shared with me describing his observations over the years. So since starting both buspirone and clonazepam, quote, she has certainly improved. Again, this is by her psychiatrist, not the parent. There's been possible improved level of functioning since buspirone was started. She's able to articulate how she feels and process an appropriate reaction. She stated that she's having less outbursts since starting buspirone. How many of your children have a lot of outbursts? Probably a lot, I would think. She was hitting herself when angry, and she has stopped doing that. If she does have outbursts, it's towards others and not directed at her mother. She was started on buspirone first, and then a little later, clonazepam. This has helped her mood swings a great deal. She is better able to deal with her anxiety, and when she gets upset, it is for a shorter period of time. So, as I mentioned before, we had already done some pretty comprehensive assessments on her. Her deletion is kind of in that medium range. She scored on the lower end for that size deletion with an IQ of about 50. And again, I think hopefully, literally in the next few months, they're going to come back down to San Diego, and Natasha, if I can bribe her, will do another assessment to reevaluate Kalia. All right, so just to summarize, Jacobsen syndrome patients have variable degrees of cognitive impairment. Deletion of several of these genes, one that I didn't talk about called neurogranin, appear to contribute to this varying degrees of cognitive impairment. Deletion of that BSX gene in combination with one or more other genes causes severe cognitive impairment, really without any exceptions that we've seen at least. Even patients with the smallest deletions have mild degrees of intellectual disability. We believe that the RIX gene is a very strong candidate gene, although there may be others, for causing autism in your children. And based on at least two of these genes, we think now that there are some very exciting opportunities for repurposing these previously used drugs that I told you about. And I didn't have time to tell you about even potentially developing a new drug based on the function of that one gene called neurogranin. So looking into the future, I think from my experience, trying to get funding, grants, the most likely trial to get funded would be one in which there's a specific gene-based mechanism that's been established that identifies a specific drug target, and where we have some preliminary data that would serve as a proof of concept. So where do we stand now for your children? Well, we're starting to treat, for example, two of those children that are missing the BSX gene with modafinil. Ideally, we'd like to do this prospectively as part of a bigger trial, but our resources are very limited. Just like we would like to for clonazepam, as we would for buspirone. That, again, is the ideal. But I think, as you can now appreciate more realistically, I think if we can complete some of these small trials on a small number of patients that I've just told you about, so for modafinil, the two patients, one from San Diego, one from Maine, that family from Texas for the clonazepam, one or two or more of those family members, and then the one patient from San Jose that's actually been taking both of these medicines. So the good news, and this is totally new information since I was here 2 years ago, is that these are all underway. And I certainly hope in the next year or two that I will be able to give you an update, and if hopefully we're lucky, maybe we'll have some exciting information to share with you. And if that's true, we absolutely will publish these findings. And I think if we do have these results, and once we publish these findings, even as just a case report, that gives you, as parents, a little more leverage and information to go back to your doctors to say, these are drugs that we know are already safe. They've been tried based on their mechanism on children like mine. I'm really concerned about my children's problems. Can we try this? So just to conclude, we have, I think, made some good progress just in these last 2 years, but obviously there's a lot more to learn, and hopefully by the time of the next conference we'll have some exciting answers. So these are the people that I have worked most closely with on the cognitive and behavioral problems. I think by now many of these names are familiar to you. And for sure, just like for you and your children, it's impossible to do this work without all of you. So I'll stop there, and I don't know if we want to do questions now or have a discussion about anything that I just talked about. Okay?
Thank you, Paul, for very exciting and encouraging results. I don't really know, whichever way you prefer. We're running on time.
Are we on time?
If you want to take questions now or
we
just afterwards.
Why don't we do questions now, and maybe even Teresa and Natasha, if you want to come back up, because really we could do this kind of as a little panel discussion for a few minutes. You think that's all right?
Right now?
Yeah.
Okay, right.
Estos 3 estudios de los que acaba de hablar son los que mañana en la asamblea vamos a votar a dónde dirigimos las donaciones. O sea que si queréis preguntar, preguntar ahora, porque mañana ya más o menos tomamos una decisión.
Sí, ¿alguna pregunta?
Hola, buenos días. Mi pregunta sería si es difícil determinar, tanto por el tamaño de la delección como por dónde se han situado los genes más implicados, ¿no?, según las investigaciones. Supongo que todavía sería mucho más complicado determinar si el paciente, aparte de la delección en el cromosoma 11, en la región que todos sabemos, si tiene también añadido otro cromosoma implicado con duplicidad u otros casos. En esos casos supongo que sería más complicado, ¿no?, decir qué grado tiene de afectación o no. Como el caso de nuestra hija, por ejemplo.
Who wants to answer that?
If there is an additional rearrangement,
if there is an additional rearrangement with the array, you'd see it. But not if it's balanced, because there may be a balanced change of position of gene, and there can be abnormality of one gene. You would only know if you analyze that gene. So you can know if there is a more complicated chromosome abnormality. But to know more is too early now. It's not, you don't have the possibility to know that at the moment. At least in all the cases, there may be specific ones where you can use advanced technology and study more details. I don't know what your daughter has got. You mentioned she has a...
Bueno, simplemente la detección de, cuando le hicieron el análisis genético, vieron la delección del cromosoma 11 y vieron la duplicidad en el número 2, en uno del número 2 en la parte corta, ¿no?, en el brazo corto. Entonces ellos no saben, o sea, es incierto determinar un pronóstico y un...
Pero eso es el resultado de que alguno de los dos padres tiene una traslocación equilibrada.
Sí, en este caso soy yo. Yo tengo una traslocación equilibrada, entonces...
Yo creo que es muy difícil predecir cómo afecta el material cromosómico además.
Yes.
Sí, ¿alguna otra
Did I
pregunta?
answer your question?
Sí, sí, gracias. Vale.
Sí, ¿alguna otra pregunta sobre estas medicaciones, estos ensayos que se...
Quería preguntar a la doctora Natasha si tenemos alguna información segura de los efectos secundarios de la medicación que ha apenas hablado el doctor Grossfeld para la concentración. Mi hija tiene problemas muy fuertes de concentración. Tiene ella no puede seguir una tarea y finalizarla. Donde nosotros vivimos no es legalmente permitido dar medicaciones a los niños, sino primero le tienen que hacer muchísimos test para saber si es que entra en el cuadro para poderle dar estos medicinas. Y quería saber más que todo, punto, si tiene efectos secundarios, si tenemos noticias seguras de los efectos secundarios. Gracias.
Concern about the side effects of the medication?
It obviously depends on the type of medication that the child would be given. In the U.S., as you probably know, medications for attention deficit hyperactivity disorder are given fairly commonly, perhaps maybe too commonly. So there's been much more research and clinical information about the potential side effects for those medications. In general, those medications are fairly safe. The most common types of side effects are appetite loss, and in some cases children have trouble sleeping and things of that sort, but they're considered fairly safe medications. But obviously you need to consult with your child's doctor to know and to monitor those sorts of side effects.
Another thing that's very important too is the dosing range. For example, the mice that were treated with clonazepam were actually treated with very low dose to minimize side effects, and they still seem to respond. So the dosing is very important as well. But in general, the 3 drugs that I talked about have all been approved in the United States, and all 3 have been used in children for other reasons. There's always some risk in taking a drug and treating somebody for a different reason. We know that, but these are the challenges that we face.
Ok, gracias.
Para
Next.
Paul, la propuesta es, ¿debemos empezar a hablar con nuestros doctores aquí? ¿O la propuesta es, debemos esperar 1 año, 2 años, hasta que haya un nivel de seguridad en el resultado?
I think that's really a personal choice. In the United States, we have a concept called compassionate care, meaning that when the situation is so severe, sometimes people make exceptions to lower the stringency or the rules a little bit if it's so severe. So I think each family has to make that very personal decision with their treating doctor. Personally, I would ideally prefer to wait at least until we know how these children are doing. But again, we know these are safe drugs. Children have been treated with these drugs before. So, unofficially, I think it's probably okay. But that's something that you as a parent have to decide And also that what's very important is your doctor has to feel very comfortable doing that.
Yeah.
Because if, God forbid, there were some bad complication, we have to be able to live with that. I think that's very unlikely, but you have to consider that when you make that decision.
Thank you.
In your opinion, from the 3 studies you're running, what's the most promising and the one which is closer?
I'm sorry, what's the most what?
Promising.
What's the most promising? That's a great question. So the question is, what is the most promising of those 3 drugs? I have to be honest and say, I think all 3 of them are very promising, potentially.
Together?
Well, that depends. So for the drug modafinil, that should be only for those children who have the BSX1 gene deleted. So if you don't know, you need to go get that test done, the CGH test. That's very important. For modafinil and clonazepam, to me, it's very exciting because the only reason why we even came up with that idea is because of the function of the genes. So if you look at the history of medicine, the best therapies are when usually, although sometimes we just get lucky and we're dumb, but usually the best therapies are based on understanding the mechanism of the problem. So that's why I think modafinil and clonazepam to me are very, very exciting. It doesn't mean they're going to work. But at the same time, buspirone, we have no idea why it may be helping or why it could help your children. But you could also say, if it works and it's safe, then who cares, right? So, does that answer the question?
Yeah. In your opinion, does it make sense to separate buspirone and clonazepam, or should we consider that as a single trial?
Let's see what happens after Natasha does the assessments on that young lady from California who's been on both. If you want to be very scientifically rigorous, you should try just one and then the other separately and then the 2 together and see if there's any difference between treating individually or together. The other way is if you feel like your child is really, really having problems, and you know what? Do both, but carefully. Maybe start with very low dose, one at a time, and monitor very carefully.